And it gives me great pleasure to introduce Angela Single, who's the Clinical Director, Telehealth and Telecare, and Chair of 3 Million Lives in Long-Term Conditions for BT Health. Thank you, Angela.
Good afternoon, everybody. Thank you for coming to hear about 3 Million Lives and the work that we're doing this afternoon. If I can just introduce what 3 Million Lives is really seeking to address, and what as an industry group we're there to support the work that Department of Health, now NHS England, wants to do in supporting people with technology to keep them well and keep them healthy in the community. So if I just give you a little bit of background, we have now been working as an industry group with the DH, NHS England, for the last 18 months. The whole pilot was launched on the back of the whole system demonstrators, which I know still caused a lot of Twitter sphere discussions, lots of discussions in areas like the BMJ, etc., about those results. So I want to just take a little time to talk about the results. So some of the results, like the reduction of hospital admissions, I think are absolutely non-disputable. We can support people to stay in the community. Where some of the controversy has been around is this cost effective? Does it affect people's quality of life in a positive way? So if I take you back to the whole system demonstrators, let's remember they were the largest randomised control trials in the world of telehealth and telecare. And because they were RCTs, the methodology that was used is the methodology that is often used in the pharma industry. And so some of us would say, well, was that the kind of methodology you'd want to use in services as opposed to the pharma or medicines, etc.? So what the whole system demonstrators set out to do were to see whether or not it affected people in a way that actually was positive, because the thoughts were actually telehealth and telecare could isolate people and actually would have a negative impact on quality of life. That was the hypothesis. The other thing it sought to do was to actually see, what I say, was it cost effective and did it actually, was it worth doing in terms of delivering this type of new service? The things that happened in the whole system demonstrator is they had to put the technology services on top of as an additional to existing health service and care services. So if you read the BMJ article that looks at was this cost effective, the thing that really comes out very closely and very clearly there is what you need to do is redesign services. And you don't do them as an add-on. And one of our mantras as an industry group is we're here to support you to redesign your health and care pathways, and I'll talk a bit about that in a minute. The other thing is that we know is that the technology that was used in whole system demonstrators was expensive. It was very early on, it was about 4 or 5 years ago now, where the price point of that technology was extremely expensive. And just as we've seen in mobile phone technology and other types of technology, those price points are coming down. And as we start to ramp up to large numbers, we as the industry group have committed to NHS England that the price points will come down so that we can affect the cost effectiveness and the price point of this technology. The final thing to note was on the back of the whole system demonstrators, the Department of Health and Miles Ayling and Stephen Johnson particularly challenged the industry to change the model of commissioning, if you like, the way that commissioners and the way that procurers of the telehealth and telecare changed. So it came from moving from a box shifting mentality that as industry we just sold you boxes to a whole managed service. So that's the background of 3 Million Lives, and we're say 18 months on. We're just going into year 2, and we've got some more plans and to support the NHS and social care and health and wellbeing boards, etc., CCGs, to help you, if you want to commission these types of services. So as an industry group, what do we do? Who are we? So we're an industry group made up of now 22 industry players, large and small, and also to ensure that we aren't seen as a cartel in any way, we also involve the 4 trade associations that represent the industry. So we wanted and set out to have the widest possible representation of industry within that group. So NHS England now can have a direct relationship with the teams that are out there working in the NHS, CCG land, etc., on a daily basis, and that has become very effective. The other thing that we are in our day-to-day lives are competitors. And for a group of competitors to get round the table, and obviously that was all encased in the Concordat that the Ministry of Health signed with us, was actually to say we will work together to support the industry, to support people and support commissioners if they wanted to commission these type of services. And a year on, there's several things that we've done. So as a group, we're motivated and bound and supporting you, want to stand side by side with you to what we all believe is one of the biggest challenges facing the NHS in terms of cost effectiveness, supporting more people with less resources and to keep them well in the community. Actually, we are bound by pride, and one of the things I think we're very proud of is that 3 Million Lives as a logo and as a brand is something that our NHS and social care colleagues have really taken up and committed to in terms of moving this agenda forward. And the other thing we want to do is we want to be supporting you to put the right kind of standards in the things that we're doing. So a starting point was, as I said earlier, was to move from a box shifting mentality where there had been some horror stories where people had sold you boxes, left them on the shelf and run in the opposite direction. What we want to be able to do is to work alongside you and become long-term partners as you start to change and radically change, let's be honest, the way that we deliver care and the delivery models of healthcare. And so what we've agreed as industry are several key things. Is that this will be a pay-as-you-go service, that's a revenue service, that isn't a pay for a box and run off in the opposite direction. That this is, you can pay for this service on a pay-as-you-go, a pay per patient per day basis, and you commission a whole service, a whole managed service. So we're still seeing procurement out there that is just going for boxes. We would always advise, if you really want to get the changes that you need to do, move away from thinking it's just about boxes, because there's a whole lot of more things to a service that you've got to think about. Don't commission in 100, 200 types of scenarios. In order to get the large-scale adoption and the large-scale move that we need from where we are to the future, you need to think about large numbers. Now, that's a challenge for both the NHS, CCGs, the industry, care managers, practitioners, to get to those large numbers. But we should be seeing that this service is a prescription-type service, where prior to the service setting up, you've thought about how you want to redesign your services, you want to think about your commissioners and tool up your commissioners and your practitioners on a day-to-day basis to be able to prescribe this service. One of the things that we've looked at, and there's a whole series of work going on at the moment, with 3 Million Lives working with the Veterans Association to look at what we can learn from the Veterans Associations. What they did there time and time again is they've taught the practitioners the tools in their toolkit, if you like, to think about how they can support patients with this technology. They've redesigned their service, and a key other aspect is the interoperability piece, so that all the technology talks and works together. And as an industry group, we're on that journey with you. So in terms of thinking about how we can support you, if you go onto 3 Million Lives website, you'll see this document. It's called the Key Requirements for 3ML Services. And what we want to do is to give you, and that's certainly what we're wanting to do in year 2 as well, give you tools and help books, etc., to think about how you can support and commission these services. So on the 3 Million Lives website, there is this document that shows you about how, if you want to, commission a whole, what we call a whole managed service, a whole end-to-end service. What is the type of service standards you want to think about and you should be thinking about? What's the type of technology standards that you should be thinking about to commission these type of services? And what can you expect from industry? So we've set ourselves those standards, we want to be beholden to those standards, and we want to give you the ability to hold us to those standards. What we know is there's a whole range of technology that can support you in your managed services. One of the things I think we should be able to do for you as industry is to take the pain of where does the box need to be? Where does the piece of kit need to be? What about if there's any issues that it's not working? How can you decontaminate it? Let us do all of that pain and help you as clinicians and commissioners get on with doing what your day job is. And so we should be able to offer you a whole range of technology which supports you in the breadth of clinical services that you want to offer. And I've been in this arena for about 13 years, and I think we've just scratched the surface. You know, we're in the long-term conditions theatre, and we tend to traditionally talk about COPD, CHF, diabetes, but actually, what about chemotherapy at home? What about kidney dialysis at home? What about end of life at home? How can we support you to deliver that technology to keep patients at home? As you can probably hear, I'm completely passionate about this. I'm a community nurse by background, and I know how much better patients do in the community. And we've seen in our own eyes the impact it does have, positive impact it has on patients and their carers and families. And so I happen to sit in an industry organisation, but I'm actually passionate about this as a clinician myself. So what we've tried to do, and this picture shows you, to move from a vendor community to a kit-only supplier, to you being able to buy service, to support you to define the requirements for that, and to support you to use your resources and your often very stretched resources in a much more cost-effective way. So, for example, you have community teams working out there on a day-by-day basis. As a community nurse, how did I know which was the right patient to target on a daily basis? Supporting you to use a whole managed service where you have perhaps a clinical monitoring centre that's working on behalf of your clinicians and your patients on a daily basis helps you to target your interventions more appropriately. As a community nurse, I know I would have loved that because it allows me to know today which patients are starting to become poorly. Because as we know, often the patients that are the ones that are going off legs or starting to deteriorate with perhaps an early stage COPD exacerbation, we don't have any robust methodology at the moment unless we use something like this to understand those and target those patients who are going off silently in the community, and the only time we get to see them is either they've pitched up at the GP surgery with an acute exacerbation, chest infection, etc., or they pitch up in A&E. How can we stop that cycle of those patients continually pitching up at A&E or continually pitching up with severe exacerbation? I believe one of the real tools in the toolkit is something like this. I also believe that it's not a one-size-fits-all, and that's why I'm very proud to represent the industry group. There isn't a one-size-fits-all, and what we should be able to do, and this is very much mirrored in the work in the VA, is offer you a range of technology. So some patients might be very appropriately needing an SMS-type texting service. Some patients might need a much more complex type of technology, which is video conferencing combined with very targeted health questionnaires and also perhaps educational content that can be run perhaps down the television or can be done in screenshots on a screen. So we believe actually there's also not one size fits all, and that actually you should be expecting us to start integrating that technology, to offer you a range of technology and not be pushing just one types of technology, that you should be able to come to your industry partners and say, work with us to provide the whole range of technology. And so this isn't about it's that box and that box is the right one. We should be thinking about clinical protocols. What are the protocols that actually are supporting that patient? Forget about the box or what we would call the form factor. Think about the types of clinical protocols that need to be embedded in these services to give appropriate care and care that we want for our patients. One of my personal challenges to myself, and whether or not I'll achieve this, is one of the things I think we should be doing, and we are doing, is talking to NICE. We should be seeing that this technology is so up there in terms of this is the way that we should be delivering services. And I'd like to get to the stage where our patients know so much about this technology, and it's again as another challenge for 3 Million Lives as a whole entity, both with us, NHS England, the NHS, social care, third sector, etc. We should have patients demanding this technology. They should be sitting in GP surgeries, I believe, and saying, I want this service. If it's saving lives, which I believe it absolutely does, then why shouldn't patients be demanding this? I recently spoke to a colleague of mine, a clinical director who historically worked in the pharma industry, and she said if we had the kind of results in the pharma industry that we had in terms of the reduction in patient mortality, they'd be singing from the rooftops. And we should be expecting our patients to demand this type of technology in the way that they are able to support themselves and empower themselves in the community. And we should start, I believe, get to the situation where we question our clinical colleagues if they're not using this type of technology, because I believe this should become, start to say this is excellence in healthcare. So one of the things we think about as you start to think about how you want to commission these services, obviously you need to think about your clinical governance, the type of management you want to have for these patients. Is it clinical monitoring you want, or do you just want technical monitoring? How do you want that to interlock with your existing services? What do you need to think about your patient selection? And we know that probably the best effective way is to have some kind of risk stratification tool. Is it a paper-based risk stratification tool? Are we just letting clinicians choose the patients themselves? Or are we going to interlock that as well in terms of the technology and flow that through into the types of services we're offering? How are we engaging with our key stakeholders? One of the things that I think is very positive if we start to see the procurement happening for these services. We're seeing that people are getting together, CCGs are getting together with the councils, with health and wellbeing boards. They're including a whole range of partners in the commissioning these services. I believe that wouldn't have happened a year ago, and we're now seeing that. The thing that I would always recommend is don't rush into this in terms of thinking we're just going to put a box out there. One of the things as industry partners we'll do with you is sit with you to redesign your pathways. Don't think there's a piece of box we like and how we're going to fit that into the service. Actually think about your service and how do you want to redesign this across the whole sector, from primary care, acute care, community care, and maybe your tertiary settings. How do you want to redesign your services across those sectors and then put the technology in it? Make sure that you've done that first, and any of the industry partners would be more than happy to talk to you about the kind of services they're offering. Understand and realise this is a huge change management. Sometimes people ask me, why isn't the adoption higher in telehealth and telecare? My answer is it's not about the technology, it's the huge cultural and change shift that we as clinicians have to do. We have to change the way we think about what we've learned, the way that we've trained years and years ago. Often we have to rethink about how we're going to deliver care. And one of my mantras is, how many of us go to the bank now to do our banking? That revolution has happened in other industries, and I think actually we're doing a disservice to our patients if we don't take that same kind of revolution and offer those type of services to our patients. Thinking about how do you want to monitor your patients, how do you want to escalate. One of the criticisms we often hear from our GP colleagues is they believe that this adds extra work to their workload. The evidence doesn't support that. What we see from the evidence actually is that it allows them, if they allow them to use this again as a tool in their toolkit, and it is all about trusted partners. We would think about, is that maybe that's where you need clinical monitoring as opposed to technical triage monitoring, but actually the evidence doesn't support that this makes more work for our GP colleagues. Also, this is a fundamental aspect of this is about supporting patients to be self-empowered, to support patients with education. And so one of the other things that you should be looking at is this is not about vital signs monitoring. This is about a holistic way to support patients with education, with understanding part of it may be understanding their vitals, so that they can be aware how maybe medication affects their blood pressure, their fluid retention, but this is a holistic way of supporting patients. This isn't also about them making dependent on some other part of the NHS. What we have to understand, though, is patients year on year are often very anxious about their own health. They see that they have very little interaction at times with the health services. And there was a few years ago, it must be about 2005, 2006, when the original work was done by the Department of Health. There was a document sent out by the Department of Health, and the quote on the front of it said, "As a patient, I live with my condition 365 days a year, 24 hours a day, and I see my clinician maybe 3 or 4 times a year, maybe as much as maybe 4 hours a year." What we see is when you offer this type of service to patients, and telehealth traditionally and typically is not 24 hours. It's probably Monday to Friday, 9 to 5, 8 till 5, 8 to 6. But the patients and their carers feel a sense of security and a sense of support that they don't believe they get from other services. And again, that's the feedback we get. So thinking about this is much wider than the old mantra, this is vital signs monitoring. And then the other thing we're doing as industry, and this is very much we're committed to doing this, is thinking about what information management do you want, what evidence and data analysis do you want to support your return on investment, how can we as industry partners support you in that risk share. And when Miles started this with Miles Aileen from Department of Health started this with industry and gave us the mantra, if you like, to get on and do this, one of his view is, how much risk share are you going to do as industry to stand up to this? If you believe in this industry in terms of the support of long-term conditions, what are you going to do? So our response has been, come back and talk to us about risk share. But the other thing is, if we're standing up the infrastructure and you don't pay for this infrastructure until you use it, we believe that's gone a long way in terms of moving this agenda forward in risk share. We also believe this is part of it should be set as in part of an integrated care pattern and integrated care pathways, and it allows us to bring all of those things together. It isn't the answer to everything, but we believe it has a really great part to play in integrated care pathways. Just how that also fits into Sir John Oldham's work in terms of how do you implement a long-term condition program, we believe it sits in the middle of there. We also believe that there's, as I said earlier, it's a continuum that you should be thinking about telehealth, telecare and telecoaching, and we haven't put the dreaded triangle up here, but it is a continuum where the technology and the technology services can play a part in that depending on patient and service users' needs. And finally, as I come to my last two slides, we have support in the 3 Million Lives team. We have a dedicated project manager, we have a website, we're building tools that we're going to be putting on the site, and we have a sponsorship from Department of Health, NHS England now, under Rachel Cashman. So there is a lot of support out there if you want support in your thinking and as you start to think about how you want to commission these services. And there is a particular subgroup from the group that is looking at what we had originally with the Pathfinders, the 7 Pathfinders that were announced, but we know a lot more people are thinking about commissioning these services, and there is support. If you go to the 3 Million website, we can support you, and we can show you, for example, there's a Worcestershire tender on the website, and that shows you what Worcestershire Council and its health partners have been thinking about how they wanted to commission this service. There is help out there if you are thinking about going down the line of, we hope, commissioning large numbers. So that's a kind of whistle-stop tour of the work that we've been doing. Please do contact us if you want more information, and we'd be delighted to help you. Thank you very much.
Okay, well, thank you very much indeed. Now, have we got any questions here? Yes, there's one here in the red.
Thank you very much. My name is Renata Drinkwater, and I'm the Chief Exec of Self Management UK, which was previously known as the Expert Patients Programme. I'm really pleased to hear you talking not just about dumping boxes on people and running away. And I think the key things that came out in your presentation for me were patient education and involvement and empowerment. And I think what we need to do is to make sure that we're not only giving patients a technological kit to monitor their condition, but also that we're giving them the sort of support that we provide, for example, which is giving them the psychological tools to manage conditions long term. So I think you need both the technology and the other resources and education for patients as well. And I would urge commissioners to think about both of those aspects. The other question I wanted to ask was, you're talking about service redesign. And to what extent are patients actually involved in redesigning these types of approaches? Because, certainly all of our people who've been through our courses are really interested in actually influencing services going forward and not just having involvement paid lip service to, as is sometimes the case. Thank you.
So just to comment on your first thing about patient education. So we see that technology is just a kind of a channel, if you like, to patients in their homes. So I would see that we would want to put more and more information down in that channel. And working with organisations such as yourself, we'd want to think about that. There are also some great new technology coming out. So people tend to come in almost on a daily basis to show me their technology. And, there's some great technology about just that. How can, maybe the television is the way to get that information down, but there are so many different form factors to do that. That's the first thing. The second thing is year 2 is a challenge for us in thinking about how can we get to patients, because year 1 was very much inward facing in terms of the industry getting our act together, and what we want to do is get patient involvement much more in year 2 and working with third sector. So what we want to do is perhaps do it at a strategy level to make sure that we've got the mechanisms to go back locally to work with patient groups, etc., in areas. So that's very much getting patients and getting third sector involved, very much our target for year 2.
Thank you. While other people are thinking of questions, my father can't see very well, he's got 2 hearing aids and his fingers are stiff. How does this work for people who've got those sort of difficulties?
So one of the most important things is, and I think we'd all say this, and I see one of my colleagues, John, just coming to the audience, is about the assessment. So just as you would assess what appropriate medication, etc., is right for your patient, you need to think about the right type of what we would call form factor, the right type of technology. So if your father, same if you've got difficult with your dexterity, assessing the type of what I would call form factor is really important. And there are technology where the box speaks to you, the hub speaks to you. Some of them are touch, so that I would say it's a touch where, as an older person, they perhaps don't have the manual dexterity. So a lot of the manufacturers have done a lot of testing about thinking about the type of how they present the technology and the questions to the patients. And simple things like the types of peripherals, the type of medical peripherals, what's the type of technology that's appropriate. So a lot of manufacturers will have done a lot of, and industry players will have done a lot of thinking about that and doing a lot of patient and user testing. Really important.
Thank you. Any other questions? There's one at the front here.
Angela, hi. Rufus Helm, BMJ. You describe what sounds like very much as a partnership arrangement between the providers and the local healthcare workforce and organisations. They need to undertake a huge amount of change themselves. It's not simply a matter of putting a tender out. How prepared do you think they are for that? And what do you think the providers will be able to do to help them along that journey?
In terms of industry providers?
Industry providers, yeah. In terms of re-engineering.
So absolutely, Rufus, absolutely. So we're seeing a whole continuum. So I talked about the Worcester tender. That organisation, those partners, have done a lot of thinking about their redesign, and they are up there and out there in terms of one of the first people off the starting blocks, as it were. We're seeing other people, and as industry we kind of grown, we're still saying, we'll trial a pilot of 25 patients, see how it works. So we are seeing a great spectrum of people, how they're thinking, and that's why as well our offer to help in that thinking before they ever put something out there in the tender sphere, if you like. So there is a huge amount. And the other thing is, what we're hearing from CCGs and their partners is kind of go away for the moment. We've got so much other things to think about, it's probably not the right time to come and talk to us. So we are seeing a spectrum. But we, as industry, if between us we've got 22 companies, plus with the trade associations as well. So you also have a lot of expertise in that group. As an industry, we, and that's why the Pathfinder sort of a support group is there. We're not there to sell our kit. We're not there to say you've got to use this box. It is about trying to come to a kind of a neutral place where you can get support and help to think about that very early on. And I think we'd ask as well, wherever you are in that spectrum, come and talk to us. And I know people get very worried about, well, you know, what about the procurement rules? We've actually gone to the DH lawyer, Diane, who said, you know, people get very tied up in the procurement laws and get very sort of just think, oh, you know, you can't talk to industry. Her view is you must talk to industry to get this right, and there are certain ways that you can do that without breaking any procurement rules, and we're hoping that as well with the industry group, because you've got a much more neutral way to do that.